to have you all here. The reason we wanted to do this training with all of you is that it's been more than a year, I think, since we had piloted using the Columbia Screener at Worcester as part of the nurse's assessment on admission. And the enthusiasm that we got at Worcester sort of got ahead of us in a sense because nurses across all of the facilities, and it was largely directed at for the nurses, started clamoring and wanting to sort of have the training and the support for also using the Columbia Screener as part of their admission process. And so we've been doing a little bit of sort of catch up with that process because it made sense to us that if the nurses are using the Columbia, that everyone else should be familiar with what is this tool that they're using, what's kind of the rationale for using it, what information does it provide or not provide, and sort of how does it fit into all of the practices that are part of our admission assessment. And as part of what we were embarked on, sort of in parallel, was reviewing sort of how DMH has approached suicide prevention, both within our inpatient facilities and in our community programs, and really trying to sort of think about what would be best practices for us as a department. And I just want to acknowledge that we're sort of doing this also at a time when probably more than ever before there's been a focus on trying to have all of our facilities, for the most part, doing the same thing. Instead of each facility sort of doing their own lit review, coming up with their own best practices, and everybody sort of doing 7 different things. So we're trying to sort of both support individual creativity and innovation and have some kind of coherent approach as a department. So here we are today, talking with all of you about sort of what is the Columbia. And some of you may know more about the Columbia than I do, and would like to stand up here and we'd happily have you help. So we're hoping this is a conversation, but sort of talking about what is the Columbia, why are we using it, and then actually we'd really like to be both talking with you about and thinking with you about how this can be part of the other parts of sort of looking at suicide, particularly while someone's on an inpatient unit here. So we're talking about the Columbia as the nurses are doing their screening, and also how it might permeate the assessment process that is part of the admission assessment. So I'll just give a little, I'm talking longer than I'm supposed to, so maybe too slow. So you may be familiar with this, and this is a slide that may not be the most up to date, but they kind of represent the relationship in the larger community between the numbers of people that report, kind of in the course of the year having had thoughts about suicide. So you go from sort of 10 million think about suicide in the general population, 3 million may go so far as to start to plan a suicide attempt, 1 million, and let me just say, as soon as it gets to suicide attempts, I always have to pause because we have no data actually on suicide attempts. I mean, so that is a really underestimate of the prevalence of suicide attempts at any one time. But you go from 10 million people thinking about suicide, 1 million people making suicide attempts, and then an even tinier fraction, 40,000 suicide deaths a year in the United States. And so there's many ways you can talk about this pyramid, but what we want to think about here is that we're really trying to intervene with folks that are thinking about suicide and planning suicide so that we don't get to the point of suicide attempts or suicide deaths. And that's sort of one of that's why we're doing screening and prevention work. So who here has heard about zero suicide? maybe half. Zero suicide is three things. Before we get to the three things, what it is also SAMHSA and NIMH have both fully embraced zero suicide as a very important priority, both in terms of the research world and also in terms of best practices in healthcare. And so so every time we apply for grant funds, every time we report on our mental health block grant, they ask us what we're doing in terms of zero suicide. Every time we apply for grant funds from SAMHSA, they want to know how we're integrating zero suicide into whatever we are applying for funds to do. So some of the reasons why we're doing zero suicide is because our major funding source has told us this is really important. So what is zero suicide? On one hand, it is an aspirational goal, and we can all talk now, if you would like, about sort of the pros and cons of even calling this campaign and effort zero suicide. I certainly have had, my first initial reaction was to not like the concept of zero suicide because it felt, I think as a clinician, it sort of felt like it flew in the face of everything that I've always known and understood about suicide. On the other hand, I've at this point spent enough time talking with people with lived experience, some of whom don't like zero suicide either as sort of a term, but many of whom have spoken about how sort of transformational it has been for them to really be part of a movement that's really striving for no suicide deaths. I think it was at I'm emerging from having been at a conference since 8 a.m. Sunday morning, so I'm a little bleary and delirious. So at some point, it was on early psychosis, so at some point in the last 4 days, someone was talking about suicide and saying something like, we used to think 10 to 15% suicide deaths was okay. And so that just gets to how we got to zero suicide as sort of being the name of the campaign. Is there was a discussion. It originated at the Henry Ford Health Center, and there was a discussion amongst a group of folks that were sort of working on a quality improvement initiative around perfect depression care, and they were saying how many suicide deaths are okay. And they basically decided that you couldn't comfortably say we're okay with 10 or 6 or 5, like sort of whose death by suicide is okay. And so you have to at least aspire to zero. It's also, in terms of what is zero suicide, it's a method for instituting organizational change in healthcare. So what that means is that SAMHSA has invested a lot in providing a toolkit and resources and guidance and technical assistance and a whole slew of effort to help healthcare systems think about, when you make organizational change, what do you need to do and how do you do it? And so part of zero suicide are sort of these core elements of, you need leadership buy-in, and that doesn't just mean someone saying, because actually our commissioner, I think 3 years ago, said, we're a zero suicide agency. We are committed to zero suicide. That's not enough, but that's, so thinking about leadership involvement and what that meaningfully means. Here in the Southeast area, Buddy has put it into the governing board's kind of priorities for the year. There are ways that leadership can really sort of put some clout behind the zero suicide is important. Training is important, and using data. So those are, think of those are best practices just in any sort of quality improvement, organizational change effort. So then the third thing that zero suicide is within that toolkit, there are recommended best practices. They're briefly sort of summarized as identify, engage, treat, transition. What it's really looking at and recommending, and I will say that this is not a static, they printed this 2 years ago and it's not changing. The research world and the clinical world are active members and people's lived experience and really sort of continuously evaluating what are best practices and how should we proceed and what does this mean for my setting. But this is basically screen, assess, engage people so you don't lose track of them, know who they are, treat them. And this is one thing that's probably not super different, but a little bit more explicitly said, which is the idea that it's not enough to treat the mental illness that gives rise to the suicidality and I think many of us who work with people who are persistently suicidal understand you have to treat the suicidality. And so DBT clearly is an evidence-based practice for treating suicidality. There are others that have emerged in the last 10 years. And then finally that periods of transition are vulnerable times, and so in addition to treating, you should also be part of assuring a smooth, warm handoff. So that's what is meant by zero suicide, all of those things. Any questions, reactions, comments, thoughts? Okay.
Is there a zero suicide at Taunton? Is there a committee in existence already? There is.
Yes.
My question is why they call it Columbia test?
So want me to answer that or what?
How about if we just put it on hold, because we're going to get to it.
We'll get to that in just a moment. I'm going to turn it over to Gregg, who's going to
So 2.5 years ago, the Joint Commission sent out a Sentinel event alert with recommendations, which basically changed the standard of care for doing suicide risk screening and assessments. So historically, people came into psychiatric hospitals and we asked them, are you feeling suicidal or homicidal, are you hearing voices? That is sub-threshold care, it's not sufficient. And we just had our Joint Commission review last week at Worcester Recovery Center, and we demonstrated for them the things that we're going to show you today, and they were very, very happy and very impressed that we sort of took seriously their recommendations from a couple of years ago. So just a few points from the Sentinel Event Alert had a lot of recommendations, but sort of the things that I pulled out that I thought were most relevant is that we now have to screen 100% of patients. So when a patient comes in, you have to screen them, you have to use an evidence-based tool. It's not sufficient to just say, are you feeling suicidal? So the Columbia is a screening tool. It is evidence-based, so it satisfies this criteria. They require that every single patient is given the National Suicide Prevention Number. The way we do that is on our social work discharge paperwork. It's just part of the automatic thing that patients get when they leave, so they all have it. They recommend collaborative safety planning for at-risk patients. So you identify somebody as at risk by screening them, and you're sort of ranking people. Are they high, medium, low risk? There's some question about how fruitful that is to try to rank people, but the Columbia does do that. It ranks people in terms of low, medium, and high risk. And if you identify somebody as having high risk, then you are expected to have communication with that person about what can we do together, how can you be involved in your own care, because it's not sufficient to just apply a series of treatments to the patient. That we don't make them get better, they have to be part of the process. You have to demonstrate that in the way that you document your notes, in the way you interact with the patients. And then finally, Margaret already talked some about this, but that our treatment plans and discharge plans specifically target suicidality. So at Worcester, there are lots of treatment plans that have safety, health and wellness, and substance abuse as the treatment problems. So safety is not targeting suicidality. It's not sufficient. You have to specifically, for somebody who's rated as having high risk, you have to have the word suicide in your treatment plan. That we are trying to treat their suicidality independent of treating the mental illness. That both are important, both need treatment, and there are different treatment approaches. In some cases, treating the mental illness actually makes the probability of suicide increase. So we need to sort of make sure that we're addressing all of these issues. Any questions about that? So here's a list of, everything on this list is truly a risk factor related to suicide. So I'm going to ask people if you can see it. I mean, literally, you could have hundreds of things on a list, but if you could pick out 2 things that you think are truly important when you do a suicide risk assessment, and I'm going to ask people to volunteer your 2 items that you pick. So, what do you find
Or
is
if
really
something's
important?
missing.
Yeah, you could pick something not on the list as well.
Absence of anything to live for. So, you know, they can't really see anything makes the life worth living.
Okay. There's one. What about number 2? What else is important?
Feeling trapped.
Mark, let me call you back.
Extreme anxiety and physical
Yeah.
restlessness and feeling trapped.
Yeah. Thank you. You don't want to? Okay. In fact, do you want to?
I don't know if this was already said or not. I'm sorry. I'm just past the history of suicidality. That's it.
Absolutely. What else? That's one. I'm going to ask
Oh,
everyone
I've
for
got 2.
Yeah.
I would also say it's not really necessarily specific, but like current living situation, like if they are housed or not. I think that's can be important.
Mm-hmm.
They have like a safety in where they're living, or depending on like what milieu they're in. So if they're on a unit, or they're in the community, or they're in a shelter, or they're on the street, that can be important factor.
Absolutely. Sure.
Hopelessness or recent loss.
Yeah.
I can't read that. so-
Yeah, that's right. They're on there. They are on there. What do other people think?
A family history,
Of somebody dying by suicide? Sure.
and also substance abuse.
Yeah.
Substance abuse. Causing a certain kind of substance abuse mood disorder, but you got depressed or something influenced by the substance. And the family history is very dangerous because you have a sample
Right.
from the family and you grew up with that.
Right.
You
It's a
know?
model.
Yes, a model.
Yeah.
Yeah, my father did it, my mother did this, so natural.
Yeah, absolutely. It does help it. You're right. Other thoughts?
My experience is more in medical field. So in medical field, usually happen, what I see is suddenly have a major, like, untreatable diagnosis, like stage 4 cancer, a new diagnosis,
Mm-hmm.
something like that.
Okay. And I'm asking for 2.
Okay, so maybe another one is the sudden death of the loved one, unexpected.
Yeah.
And they have a good binding, for example, as mental retardation patient has been really taken care of by mom, and all of a sudden mom died from a stroke suddenly or heart attack, and that be a big stress for the son.
Right. Thank you.
Serious financial problems, and then the local epidemics of suicide.
Mm. Absolutely. Yeah.
I would say pending legal charges, where you don't know what's going to happen yet, and then also a loss of identity. So that could be like a loss of a job, or a loss of a loved one, or a loss of a child. Like if you're not a mother anymore, then what are you? So anything that really is changing how they identify themselves, if that's taken away from them, they're at risk.
Mm-hmm.
If I may, one sentence there, showing rage and talking about seeking revenge. I was an emergency doctor in Hungary, and Hungary, unfortunately, on number 3, or always a 1, 2, or 3 on the list of the suicide.
Mm-hmm.
And a lot of person died because they want to punish the family, they want to punish the loved one or something like that, because disappointment or something. A lot of hanging and so on and so forth.
Right.
So they full with this rage and anger, and I will punish them, they will miss me.
Yeah.
And it's too late when you're already dead.
Right, and that ties into murder-suicides also. And when people are, if I'm going to kill myself, you're going with me.
Mm.
Thank you. You miss anyone? So, each of you, and I would have come up with 2 different ones, like we all came up with different things that are important. So I want to go on a slight tangent for a moment. In social psychology, there's a thing called illusory superiority, which is sort of a delusion that we all maintain that, like, people rate themselves as being better at things than they actually are, like driving. Right? So everybody thinks they're a good driver and nobody else is a good driver. So statistically, if you ask people to rate their own driving, 64% of people will say that they are an excellent driver or a very good driver. And statistically, that's not possible. Like, they're probably average drivers. Most people are average drivers. But they rate themselves as excellent drivers. And they rate their friends at 29% being excellent drivers. So I'm great and my friends aren't. In my peers, people my own age, 22% of them are excellent drivers. And people from surrounding states, 8% of them are excellent drivers. Right? So the further away the person is in terms of a relationship with you, the worse they are. So what does that say about us? Like, if we're thinking about assessing suicide risk, we all have our own ideas of what's important. We all think that we're doing a good job, and we probably think we're doing a better job than our peers. Like, I'm great at it, and you guys are okay at it, and the people who didn't come today are terrible at it. Right? So what we want to do is move from this perception that we're all great at it to using evidence. And that's what we're going to talk about today, is how do we actually use evidence rather than a collection of hundreds of things that all are true, but there's no weighting attached to any of them. Yeah?
Doesn't evidence suggest we all suck at it, actually?
Yes.
Okay.
Yes, you are right.
Appears to be true.
All right.
Right, we are
Just make it true.
notoriously terrible at
Excuse me.
accurately assessing suicide risk. Part of the reason for that is that there has historically been no weighting. Like, you can't say that this risk factor is more serious than this risk factor. Like, there just isn't enough data to demonstrate that. So we ask people to use their clinical judgment. Like, you decide, like, among the collection of factors that elevate risk, what's important, what matters to this individual that you're sitting with. And everybody has a different clinical judgment. So you could think high risk and I could think low risk for the same set of risk factors. I'm going to ask, these are some risk factors taken from that other list. Can you look at these? Being male, white, Native American, divorced, family history of suicide, family history of trauma, chronic medical illness. What do these things have in common? Are they all similar?
The static.
Yeah. Yeah, exactly. These are static. Use the right word too. Perfect.
We did this before.
So they're static.
Did you see the slides?
No.
So what does it mean? It means that they all exist, they all increase somebody's vulnerability statistically, but there's nothing you can do about it. It's not treatable. You can't change any of that. So it might be an interesting piece of their story, and you might want to include it as you're writing about a person, but it doesn't help you decide what to do. So the second list here, these are dynamic risk factors. These are things that change. These are things that our interventions do make a difference for. So we really need to emphasize when we're doing suicide risk assessments, is this person hopeless? Well, we can use cognitive behavior therapy to help modify hopelessness. Or does the person have insomnia? There's medicines and cognitive behavior therapy for insomnia. There's treatments that help modify dynamic risk factors that reduce somebody's vulnerability. So it's important to know that static factors exist, but they're not predictive of anything. Dynamic risk factors get closer to being predictive, and they're the things we can treat. So it's important that we make that distinction. Thoughts?
But the liability is difficult because you're assessing the risk, but you don't know the patient's telling you, no, I'm not suicidal, and he is suicidal. You know what I'm talking about. And I always dreaming about this, some kind of suicidal EKG that we collect some kind of bioelectricity from the patient, and it shows that the patient
We have almost that. That's what we're going to present today.
I didn't know that.
It's basically the best that we have, the best that the field has, but it's actually far better than any of this.
Oh, I didn't know that. Okay.
So that's the direction we're moving in over the course of our 2 hours today.
Okay.
It's not a medical test. So this is a list of risk mitigating factors or strengths or coping strategies. And all of these things involve being connected, having family, having a support system, having reasons for living. All of these things, historically, people used to call protective factors. We discourage people from using that word protective because in the research, there's actually no proof that they stop a person who's in a suicidal crisis from killing themselves. So they may help mitigate or reduce the odds that somebody gets to a suicidal crisis. But once they're there, they are not protective. So the word protective really isn't a great thing to put in your notes because it's a loaded word. It implies that, well, this is going to keep the person safe. And it's just not true. That once a person has become intent on ending their life, there is nothing that is actually proven to be clearly protective. So having a family, lots of people with families kill themselves. So you might say it helps minimize the chance of getting to that point, but once they're there, it's not protective. So we want to encourage people to use risk mitigating factors, strengths, coping strategies in lieu of protective. And then one final point, a distal risk factor. Everything we've talked about so far are basically distal risk factors. They're things that increase somebody's vulnerability, but they're not actually predictive by themselves. So if you can imagine this cloud being somebody's overall vulnerability for suicide, some of the factors are static, like the cloudiness might be that a person is geriatric or a white male. So there's not much you can do about that. That cloud of risk is going to remain, but some of the risk factors, like insomnia, you can sort of pop that bubble. You can reduce their overall risk by treating things that are dynamic factors. So what we want to do is try to identify what are the factors that we know increase their risk, that there's something we can do about, pop those bubbles. It doesn't mean their overall risk is gone, but the magnitude of that risk is diminished. All right, so this slide is basically showing what our objectives in meeting here today. Everything we've talked about so far is like background information, but we are here to learn about the Columbia Suicide Severity Rating Scale, which is already being used at some sites, to try to help organize and understand different degrees of suicidal ideation, to try to adopt the Columbia language in the assessments that we write, to talk about the acute suicidal affective disturbance as a way of assessing acute risk for patients who are identified as having high risk on the Columbia screening tool. To also talk about capacity as that relates to elevated risk. And basically to try to tie it all together. In the end, we're going to have an example of like how do you tie it all together. So you screen somebody, you assess somebody, and hopefully going forward, treat somebody.
I have a question.
Yes.
Are these slides going to be available to us?
Yeah, we will send the whole PowerPoint presentation to everyone who's attending today. So the Columbia Suicide Severity Rating Scale was created between 15 and 20 years ago. The FDA back then was concerned that adolescents who were being put on SSRIs had an elevated suicide rate, and they said, this isn't acceptable, we need to do something about it. So they got Columbia University, that's why it's Columbia, to create something to help them screen the adolescents. What they created ultimately became the gold standard in the field. It wasn't intended to do that, but they did such a good job. They didn't just use their own research. They pulled in Beck's research group, who does the hopelessness scales. They basically took all the best knowledge that existed at the time, pulled it together, and created a suicide risk assessment screener. So much of what we're going to talk about today is the screening tool. There is a longer version. There's one slide you'll see later in the presentation about the longer version that they created. But we're using the Columbia as a screening tool, so we're using a shorter screening version of the tool, which I'll hand out in a moment. So what it is a semi-structured interview, meaning that there are prompts. There's a series of questions that you can ask. But if you can gather the information without asking every question, that's okay. That basically you need to understand the concepts that are involved in the Columbia and ask sufficient questions to get the concepts answered. So you don't literally have to ask every single question the way it's written, but you do need to understand what is being asked. I encourage people when they're first getting used to using the Columbia, use the language that they recommend until it becomes permanent in your head. So it is an evidence-based tool, so JCAHO's happy with it, CMS is happy with it, Action Alliance for Suicide Prevention is happy with it, because it advances our practice beyond what it has historically been in terms of stratifying suicide risk. And it's pretty quick and easy to use, and it has lots of research behind it. You can go to the Columbia website, you can type in C-SSRS in Google search, and you'll get tons of articles. It's already used worldwide. And because it's become the gold standard for screening, anybody who applies for research grants now related to anything having to do with suicide, they are required to use Columbia language. So you can't, basically what we're trying to do is get everybody in the mental health field to all be sharing a common language when we talk about risks for suicide. And the Columbia is the best way we have to do that. So I will hand out a copy. This is probably the easiest version of this Columbia screening tool to look at because it's got colors that help you to see where the low, medium, and high risk is. So this is exactly what's being handed out. This is the top half of it, which is only talking about suicidal ideation. And there are 5 questions here that each have to do with different levels of severity of suicidal ideation. So the first one, have you wished you were dead and wished you could go to sleep and not wake up, is the most mild. And they just get progressively more severe. Have you started to work out or worked out the details of how to kill yourself? So that would be the most severe, the number 5. So in a sense, the Columbia scale stratifies the severity of suicidal thinking, which hadn't existed before. It used to be yes or no. Now there's a stratification. There's 5 levels to consider. And they have different meanings depending on how people respond. And then the second part of this is question 6 here has only to do with behavior. It does not have to do with suicidal thinking. So the first 5 are stratifying suicidal thinking, and the 6th question is about behavior. And we're going to go through all of them individually.
Can I say one thing?
Yes.
I don't know if you mentioned this. You may or may not have paid attention to the far right of the column, which orients the questions to a particular time frame. So we'll say a little bit more about the time frame, but I also just want to acknowledge in different settings that time frame may change. You know, if you just saw someone yesterday and you're reevaluating them, you're not going to ask about the past month, you're going to ask about the last 24 hours.
So for the suicidal ideation levels, there are 5 increasingly severe levels, and it doesn't say it on the scale, but it should be suicidal ideation severity, because we're rating how severe is this person's thinking. So the first one is called a wish to be dead. You know, have you wished you could go to sleep and not wake up? What is that, just in historic language, what does that sound like?
That's
What?
delicious.
Passive, yeah, it's passive suicide. It's, you know, it's not, no intent or no desire to do anything myself, but if I died, that would be okay. Passive, it's no different, it means the same thing as when you think of passive, wish to be dead. But we are trying to adopt Columbia's language going forward. So rather than writing passive, we would encourage you to use wish to be dead if that's what you're rating someone. Suicidal thoughts are exactly as it's always been. Like, do you have some thoughts about wanting to kill yourself? That's no different. Suicidal thoughts with a method, this tends to be the hardest thing for people to understand. That if I tell you, I'm thinking of overdosing on 40 pills, that is not a suicide plan. That is a suicide method. It's a means by which somebody could kill themselves, and that does not identify a high-risk patient.
By itself.
Not by itself, right? Somebody who has just identified a method or a means by which they could kill themselves, they might be scary, you might not like that they said that, and you may want to do things about it in terms of treatment, but that's not the high-risk person who's likely to die by suicide, if that's as far as they get in terms of severity. So methods are different than plans. The 4th most severe level is somebody who has suicidal intent, basically meaning that they have gotten themselves past what we normally think of as self-preservation. Like, most people don't want to die, and it hurts to try to kill yourself. It doesn't feel good. Most people don't like it. If somebody can mentally get past that and say, like, I'm going to do it. I will end my life. That is a higher risk person. That's something we really need to be concerned about. And then even beyond that, somebody who has intent and they've worked out the details of a plan. So a plan is much more specific than just a method. It's, you know, next Thursday nights when nobody's home, and, you know, I've got a gun in the safe downstairs, and they take the phones off the hook. Like, you know, they've got all the details worked out, and they know the exact method and time and place. Like, it's all coming together. That's a very high-risk person.
It could be somebody with a plan without intent, right?
So this is a problem with that people who criticize the scale, they say that because this is a gut-in scale, which basically means that if you say yes to 2, it's presumed that you said yes to 1. And if you say yes to 5, it's presumed that you said yes to everything under it. And people who criticize the scale say, well, that's not true. I know patients who say yes to 5, but they would say no to the ones below it. You're right, it's not perfect. It's not automatic that everybody is going to have a yes to everything beneath. Sites who adopt the Columbia have dramatic decreases in their suicide death rates. So whether we like it or not, or we think we can make a better scale, nobody has made a better scale.
That's fine, I just wanted to make sure that.
Yeah, you're absolutely right, that it's possible that somebody is hearing voices and the voices have a plan for them to die, but it's ego-dystonic, they don't want to die, they have no intent to die. So clearly you could have a plan with no intent.
Well, a lot of people have a plan on hold, and they put it somewhere mentally and kind of protect it. This is when it comes, I can control my life, I know how to do it.
Right. Yeah, so you bring up a great point, and I won't argue it, because I think you're right. Like, it's possible for people to not say yes to everything. It sort of doesn't matter, because what we're looking for is the highest level that they do respond to yes to, regardless of what they said on the preceding levels. The suicidal ideation severity rating, the thing you're going to write in your chart, is their rating is a 5 if the answer is yes to question 5. So there's no math involved. It's not a score. And lots of people get this wrong. They try to like add things together, and like there's all different ways people misuse this. But it's just simple. Like if they answer yes, whatever the highest question they answer yes to, that is the severity rating. So, and again, if people say yes to question 4 or 5, those are people that we perceive as having high risk, not because Worcester thinks so or DMH thinks so, but because the research that Columbia has done has proven that those are the people who are more likely to die by suicide. So these questions are exactly what's on the form that you're looking at. The rules around using this scale say that every patient needs to be asked upon admission the first 2 questions. Have you wished you were dead, or wished you could go to sleep and not wake up? And have you actually had any thoughts of killing yourself? If they say no to question 2, I have not had thoughts of killing myself, then you do not continue with question 3, 4, or 5, because they're describing more severe levels of those thoughts of killing yourself. So in a sense, if somebody says, no, in the past month I haven't had any thoughts of killing myself, and you start asking them, well, what method have you thought about, and what's your intent, then you're sort of losing rapport with the person because it just doesn't make any sense. So question 2 is sort of the decision point. If you've had thoughts of killing yourself, then you must ask questions 3, 4, and 5, all of them. So it's basically only 2 ways to use this. You either ask 1 and 2, and then you skip on to number 6, or you ask 1, 2, 3, 4, 5, and 6. Yeah, you have a question?
So you had mentioned at the beginning it's not good enough just to say, are you thinking of killing yourself? But if they say no to number 2, that's actually all you're doing.
Right, but you have put that on a stratified scale, and your note isn't going to say no SI, it's going to say C-SSRS rating equals 0 or 1 or 2, whatever your rating is. So you're demonstrating that you used the standardized screening tool as opposed to just that. In a sense, you're right.
So liability-wise, that's great, but that's really no different than somebody just saying, sorry, you think you're killing yourself. You know what I mean?
I want to ask you a question. Dr. Lacombe, you have this patient in a wheelchair who's not eating, and passively suicidal, basically. Electrolyte imbalance, I'm talking about. So where are we now in this case?
We are at, he's telling me he's not thinking of killing or hurting himself.
He's telling you?
Yeah. I wouldn't go beyond 2.
All right.
So I think that the intention of this is to provide, in some sense, it's to correct the under-asking of questions. Because, and it's interesting because it's intended for healthcare, behavioral health, community settings, et cetera. And so often the Columbia, I understand everybody here has been doing this for a zillion years, and you all have ways of establishing rapport, creating a context for people to then disclose what's going on for them. The intention, one of the purposes of the Columbia is for people who are not comfortable asking questions, to actually give them a structure and a language. These are not the only questions, so part of semi-structured is these are not the only questions that you can ask in order to get the information that you need to make a good judgment. And I was thinking, we have a nice article. There was a psychiatrist at MGH who was recently interviewed talking about his work for years. And with some patients, he wouldn't ask 1 or 2, he'd just go straight to 3. Because he already knows, that he knows the patients well, he knows that they are sort of persistently suicidal. You don't have to ask that question if you want to go, you can go straight to 3. So it's not meant to prevent you from doing what you do well in terms of helping people be comfortable to talk about what's really going on for them. It's a tool.
I was just gonna say too, and I'm sure you're gonna get to this as well, but it's also based on all sources of information.
Yes.
Right.
Yeah, we will
Yeah.
talk about that in just a moment.
And then also, I guess you'd also say that we would like them to document this is what their Columbia score is. However, they have incredibly poor insight, and I would really question the accuracy of their own judgment. So you would start off with it, and then you would just go from there, would be the expectation?
Absolutely. It's a screening tool. It stratifies people, but it is not a suicide risk assessment. And so we want to make that really clear, that this is only a screening tool to get the ball rolling just so that we make sure every single patient has been screened. But we're gonna talk about what do you do as providers when somebody has an elevated scale, then what? How do you think about your assessment? We're gonna talk about that in a moment. So just one other thought about it being, about not having to ask every question. If I were to ask someone if they wished they were dead and wished they could sleep and not wake up, and they said, well, yeah, last week I jumped in front of a car, I mean, I want to be dead, I tried to kill myself, it didn't work. I don't need to ask any of that. I already have the answer, so I already know, right? So I may just get into a conversation, like, what was going on for you, like, how did you get to that point? But I don't need to stick to the Columbia.
How about the woman is 35, recently divorced, drinking, has a suicidal history, and has 3 children? You are asking the first question, or going for the 5?
Right,
Well,
so,
I think, I mean, you would, just based on what you just shared, I would start with the questions, because I'd wanna know what her current state of mind is in the context of.
But I
what you
mentioned the
just
5
described.
point for this by the book. You know, divorce, alcohol, previous history,
yeah.
currently drinking, and 3 children.
Yeah, so, but again, that point we were trying to make earlier is that understanding that there's distal risk factors, they all increase vulnerability, but they don't predict. And so we're trying to move towards using evidence-based to get closer to predicting. It's not a perfect science, but we are moving in that direction. We have things that actually help us predict.
Can we go back to the last slide? I just had a question about number 3, suicidal thoughts with method.
Yeah.
So let's say someone says, I don't have a plan to kill myself and no intent, but if I would kill myself, I would use pills. That would be,
Yes, absolutely. That would be a method, yeah. That's almost exactly like the examples they use in the Columbia training. So suicidal behavior, so the CDC that publishes death certificates lists only 4 possible ways that people can die on a death certificate. And so their definition of suicide, death caused by self-directed injurious behavior with an intent to die as a result of the behavior. So the intent is the important part here for us, is that people may, like somebody could be dancing on the top of a 10-story building and fall off, and that is not suicide if they fell off. But if they understood that this is a high-risk situation and I don't care if I die, if part of them thought this might kill me and I'm going to do it anyway, then it is a suicide. So their intent matters in how you determine the cause of death. So Columbia's language is a little bit more specific but almost identical. A potentially self-injurious act committed with at least some wish to die as a result of the act. So they have to understand, even if just a tiny fraction of them understands that what they're doing might kill them, they have to believe and understand that that's a possibility, and they do it anyway. It's an important point. If they do it with
Some wish to.
some wish to die, right? Like, so I'm gonna do this, and if I die along the journey, so c'est la vie. Like, I'm okay with being dead. And it matters more what they think, what their mindset is, than what our mindset is. So if somebody tells you, you know, I took 5 Paxils because I knew that was an overdose, and we know 5 Paxils won't kill you, but they thought it might, then it's a suicide attempt. Even though we conventionally believe, well, that's not sufficient to kill somebody, it doesn't matter that we don't think that. It matters that they did the behavior with the belief that it might kill them. So Columbia breaks down suicidal behavior into 4 different kinds of suicidal behaviors. So actual attempt is everything we've already been talking about. An interrupted attempt would be somebody who starts the process and somebody else gets in the way. So, you know, they're pouring the pills in their hand and somebody else comes by and knocks the pills out and calls the ambulance and says, let's get you some help. And an aborted attempt would be the person doing that themselves. They start the process and they say, I can't do this. But mentally they already got there. Their mind was already ready to engage in that suicidal behavior. And then a preparatory behavior is exactly what it sounds like. It's buying rope for a noose or hoarding pills, it's writing a will, it's doing things to get yourself in a place where you can kill yourself. So Columbia breaks this down into 4 different areas, and I want to ask, what do you think in terms of risk? Which of these puts somebody at higher risk or lower risk?
They're all high risk.
Say it again?
They're all high risk.
How come?
Yeah.
Because the thoughts
intent.
went past just thoughts. There's intent there and planning.
Once you're acting,
Yeah, it's actually, yeah.
You are the first audience that has said that. You're right, it was a trick question. You guys are the first people who have ever accurately saw this, is they are all equally, statistically, they are equal. And almost everybody, including me, when I first saw it, I thought, well, of course, actual attempts would be worse than preparatory behavior. But no, they're not. Statistically, who dies from suicide, they're all the same. Because of that, because Columbia has done research and recognizes that they're all the same, their behavior screening question combines all of that into one question. So in the last 3 months, have you done anything or started to do anything or prepared to do anything to end your life? We don't need to stratify those questions because statistically it doesn't make any difference. If you've done any of those things, you're at elevated risk. So there's only one behavior question on the screening form.
That doesn't mean you have to ask it all as one question. You can break it up into, 3 parts as you're asking it, but in terms of rating it, it's a single question.
So this is what it looks like in our MHIS system, which has a lot more words than what's on the paper that you have. It's the same scale, so I'm going to go through it. Basically, each row going across is one topic. So here's just one row. This is the 3rd question. So it's asking about methods, and at the very bottom it says ask, and there's the question. It's the same as on the sheet that you have. But then there's a long description of what exactly is this question trying to get at. So this one's about method. The person endorses thoughts of suicide and has thought of at least one method during the assessment period. This is different than a specific plan, time, place, or method details worked out. So if you understand what the concept is that it's looking for, you can vary the way you ask the question. You just need to be able to understand what's the intent of this particular question. So in the MHIS, the first 5 questions are asking about suicidal ideation in the past month. The current version that we have in MHIS as a screening tool, ideation is past month, behavior is past 3 months. That's the same as the one that you have. And then the behavior question is also repeated word for word down here, except this is lifetime. Same exact question, but in your life, have you ever started to, it's the same wording. And then there's this thing that we stuck in the middle because our MHIS sort of couldn't do math, so we had to fill in this question to identify who's the high-risk patient. So, did the patient respond yes to item 3 or 4, or 4 or 5 or 6, which are the high-risk items. So somebody who has intent, or intent with a plan, or any behavior in the past 3 months, those are the high-risk patients. And so this question here is asking, nurses are doing this on screening, is question 4 or 5 or 6 yes? And if it is, they check yes here, and that flags the chart as this person is, upon screening, on admission, a high-risk patient. So that's going to change what we have to do going forward with this patient, because we've flagged them now. So when they try to enter that, and it says, yes, they're a high-risk patient, this is going to show up basically prompting the nurse to say, oh, hold on, you just identified this person as high risk, either initiate or continue the elevated suicide risk protocol. This protocol may be different in Taunton, in Worcester, and other sites. It doesn't have to be the same exact protocol, but you have to have a protocol. What do we do once we've identified somebody as having elevated risk? So the Columbia is our screening tool. 100% of patients get screened. the patients who are deemed to be high risk, we have to either initiate or continue, and you have to have a protocol to do that. Does that make sense? So generally the nurses are doing this, but we talked about this before. There's only two possible ways that we want them to fill in the Columbia. So if somebody has suicidal ideation, they ask questions 1 and 2, they say yes, they continue on, question 3, 4, 5, 6, they ask everything.
So the green doesn't mean they said yes, it just means that if you're auditing a chart, there should be a response to every single, if they said yes to 1 and 2, then every other item should have a response recorded, or a rating recorded.
Right.
I have something similar in Oregon. Oregon.
Yeah, Corrigan started using this about a year and a
Yes,
half
because
ago.
I'm more liking that than to doing this.
Yeah.
So then if a patient does not have suicidal ideation, they said no to question 2, then you do not ask and you do not fill in question 3, 4, or 5, and then you continue on and you ask all the remaining questions. So these are the ways we want to see charts documented, and when we audit, we're going to try to encourage nurses to be doing it this way. But it doesn't make sense. You wouldn't go in and answer no, no, no to 3 questions that you
So you're gonna
didn't
leave
ask.
those blank?
You
You're
leave them
telling
blank.
people to leave it
I'm
blank?
actually asking Ann Goldstein if she
Okay.
can force the computer to
Oh,
leave
yeah.
them blank. She thinks she can do it, that once you answer no to this, the cursor would bump you down to 6. Currently, it's not that way, but she thinks that she can get it to do that. But our intent is, like, this is what Columbia, on that sheet that you have, the colored page, this is what's on there. It says skip questions 3, 4, and 5 if the answer to question 2 is no. So if Columbia is telling us to skip them, we want to skip them.
This says skip 6 also, right?
No.
No.
If yes, 2, question
Oh,
3, 4,
okay.
5, and 6.
Oh, I got you.
No
Okay.
No
to
to
2,
two.
I that will go to
Directly to
6
Thank you.
questions.
It's like Monopoly, you go directly to jail.
No $200.
So this is sort of a chart to show who's at elevated risk. The whole point of the Columbia is to stratify people. So I suggest you look at just this column for right now. So the people who don't answer anything a yes are very low-risk patients. And the patients who say yes to questions 1 and or 2 are still low-risk patients. Lots of people have chronic suicidal thinking, but they're not high-risk patients until they sort of move up the scale. Somebody who has identified a method is a moderate risk. Somebody who's identified a method with a plan is a high risk. And then the last one here, very high risk if they have a method and a plan and they've got some history of suicidal behaviors or previously having gotten to that point. If you sort of think of it as like, again, if they got to the point where they knew they were going to kill themselves, they got past self-preservation, and they've done that multiple times in the past too, their risk is greatly enhanced. People who make suicide attempts are at more risk than people who haven't for future death by suicide. So this is sort of important. It's what we've been talking about. It's what the colors help you see on the version you have, that the items that are colored red are the high-risk ideation or presence of behavior. And again, the behavior is a 3-month window, a 3-month look back, and the ideation is a 1-month look back. So we encourage people to never use just the patient as your source of information, because many patients will say, no, I don't think suicidal at all, but that doesn't mean they don't have they're not in an elevated risk state. So we want people to use other sources of information and always rate on the Columbia using the most severe information you have available. So if the patient's saying, no, I don't feel suicidal, but the emergency room that sent them to you says, well, they were telling us about their suicide plan, that's why we admitted them to you, you're going to go with the emergency room. Yeah. So we encourage the nurses always to identify multiple sources that they used in coming up with a rating. Questions about that at all? this is an example, a made-up patient. So we're basically going to go through and try to rate Sarah X here. So Sarah was sent to State Hospital from MCI Framingham with an 18A referral after not eating for 2 days, banging her head against the cell walls, resulting in bruising on her forehead. She stated that she intended to kill herself by jumping off her bed and smashing her head on the floor. She reported to her corrections officer that all these behaviors were attempts to end her life. And then she shows up at your hospital, and she reports not feeling suicidal at all because she believes she can get the treatment she needs in the hospital. She doesn't appear to be in distress. She's socializing with other people. She's not isolative. She doesn't look depressed. And she explains, I just had to get out of there. MCI Framingham. Very typical referral for us in Worcester. People in jail feel miserable, suicidal in jail. People come to the hospital, change of heart, feel different. So how do we assess? What do you think?
We have to go with more severe information. Yes.
Okay, so in the past month, has she wished to be dead or wish she could go to sleep and not wake up? Maybe. Or has she had thoughts of killing herself? Has she identified a method? Has she had some intent? And did she have intent with some specific plans? Yep. Yeah. So this person we would rate as having a 5 on suicidal ideation severity, even though she's in front of you saying, I am so glad to be here, you guys are great, and I've got friends here, and I'm going to use treatment and get myself better. She's a high-risk person statistically because within the past month, her brain was capable of going to that place where she wanted to kill herself. And it may just take an argument with someone on the unit, a fight, a phone call. It may take very little to get her back into that acute suicidal crisis. So it sort of doesn't matter how they present at the moment, it matters what's been going on over the past month. And again, Columbia did research on who ends up dead. You could sort of trace back what was going on for the person, what is their risk state over the past month, in terms of thinking, in the past 3 months, in terms of behavior. So what we do, once somebody is identified as having an elevated Columbia scale, is we try to keep them safe. So nursing has to contact a member of psychiatry or a doc on call, saying, this person's on CO. If they weren't to begin with, they are now, because they're elevated. And the doc on call with the psychiatrist then has to do a more comprehensive assessment. So far, all we've talked about is a screening tool. We're going to talk about what does that comprehensive assessment include in a few minutes. So evaluate for acute risk, that's what we're talking about with the assessments. The nurse fills in the Columbia in MHIS, and we ask them to always include multiple sources that they used. So we're almost done with Columbia. I wanted you guys to see what the long version of the Columbia looks like. So you have the screening version, which is completely acceptable to be used as a screening tool in a hospital setting. When Columbia was doing the research for the FDA, they basically had a much more comprehensive tool. So suicidal ideation is here. This is the severity. This is the 5-point rating scale that we've been talking about. Underneath that is intensity. So if somebody has high severity, you may want to ask, well, how often do you have these thoughts? Is there anything you can do to protect yourself? So there's all kinds of prompts to help you flesh out the details of this person's thinking. And then the flip side of it is all about behavior. The 4 levels of behavior we talked about, they're all combined into one question on the screening, but they're separated out into a whole bunch of questions on the longer form. And then there's potential lethality of the methods they used down at the bottom here. So we're not asking you to learn or do this, but it's probably good that you understand it exists, and I would encourage you to look at it because the language here is the language that's the field is going to be using going forward.
Do you have copies of that one to hand out?
I don't have a paper
We can
copy of that.
distribute it to you, and it's pretty consistent, with the suicide rating, suicide risk assessment that's used on the inpatient units. Currently, they look, and I think probably many of you who do suicide risk assessments may already be thinking about these kinds of things, but we'll do definition.
Right. We will give you this PowerPoint presentation, like you'll all get that anyhow, and you can type in C-SSRS into Google and get copies of all, there's no cost for any of these scales, so you can get and print those. So now we're going to sort of shift gears. We're done talking about Columbia for the time being, and say, so how do you identify a person who has acute risk? If we say this person's in an elevated risk state based on their Columbia score, okay, so they're in an elevated risk state, but lots of people, like Sarah X, are going to be screened in as elevated risk state, but we don't want to keep Sarah X on constant observation for the next month. That just doesn't make any sense. So we want to figure out, how do we assess for acute risk? Who's the person who we need to worry about? Like, they're going to try to kill themselves here in the hospital. So you may be familiar with this, but Thomas Joyner, he's a psychologist down in Florida, has spent his whole career studying suicide. He's probably the most prolific writer about suicide. And he has outlined what he calls acute suicidal affective disturbance, which is 4 criteria that are intended to become a DSM diagnosis that are predictive of death by suicide. Imminent, right. So when we talked before about, I wish there was a medical device or a way we could sort of figure out, well, who's actually going to die by suicide, this is the best we have right now. But with years and years of research, tons of articles that you can look up, it pretty consistently, when they do autopsy, psychological autopsies after the fact, these things are almost always present in people who die by suicide. So we're going to go through them individually. So the first criteria is a geometric increase. Oh, actually, I have a copy of this for you. Sorry. A geometric increase in suicide intent over the past couple hours or days. This is not somebody with chronic suicidal thinking. That's not a geometric increase. And this is not just about thought, this is about intent. We just used the Columbia to screen in the people who have high intent. So this is asking about, has their intent bumped up in the past couple of hours or days? So a notable change in their intent is predictive of, it's one of the 4 factors that is predictive of death by suicide. So the second criteria has 2 parts to it. So the first is marked social alienation, which is what a lot of nurses think, like severe social withdrawal. People will observe a patient like staying in their room, not going to group. That's a piece of it, but it's also, it's bigger than that. It's an example from Robin Williams. I used to think the worst thing in life was to end up all alone. It's not. The worst thing in life is to end up with people that make you feel all alone. So Robin Williams, by most people's accounts, was successful and had family and had friends and money and had anything he wanted. You might think all of those things were protective, right? But when somebody gets in an acute suicidal state, protective factors don't protect. So, he's basically describing, yeah, I got people around me, but they don't make me feel connected. They're not, they don't value me, I don't value them. So if somebody gets in that state where the social environment is not valued or important or perceived as important, that's a high risk factor. The second half of Joyner's criteria here, number 2, is self-alienation, and that's more of like disgusted with your own humanness. Like, I just can't stand myself, I can't do anything right. You guys would all be better off if I were dead. Which this says, people will be sad at first, but in the long run, if I think it's for the best, I'm certain they're better off without me. This is self-alienation. Right? So Joyner's second criteria is one or both of these things. It doesn't have to be both. Either one of them would satisfy this criteria. So either the social environment or the sense of self, like I'm a burden on the world, would meet this criteria. And then the third of his criteria is a perception that those first two things are hopelessly intractable, meaning this person's developed tunnel vision. I'm such a burden. Suicide is the only thing I can think of that is going to make any difference. I need to just end the pain. Right? So the problem here is that the person, not just that they're hopeless, like I can't get a job and my girlfriend doesn't like me. That's hopelessness, but that's not what Joanne is talking about. He's talking about specifically related to the first two criteria. So you've identified suicide, a bump up or an increase in suicidal intent, and you don't think there's any other option, and you feel either socially or self-alienated, and that's never going to change. So I think of this as tunnel vision. There's no other options other than killing myself. And then the final criteria, if you can imagine somebody who has everything I just described and their body feels miserable, right? So they're either not sleeping or they're agitated or irritable or having nightmares, that basically they are in a state of fatigue. Any of these things would indicate fatigue. If your body feels lousy, I tried to get a picture of somebody who looks like, you know, she's in distress, she feels awful. If you feel physically awful and all that other stuff mentally is going on and you think suicide's the only option, what else have you got to live for? Right? So Joyner says that 2 or more of these criteria are always found in people who die by suicide. So for psychiatrists, when I talk about this in terms of treatment, because we talked at the very beginning about, can you identify dynamic risk factors that you can do something about? Every single one of these, there's a medicine for. Insomnia, how do you treat it? What would you give? What's the choice?
You can put people to sleep with a lot of things.
Okay, then choices and nightmares? Medicine for nightmares? Rosacea? Yeah. What about somebody with agitation? What might you give them?
I think there's so many different things. I mean, you could do a bedside, you could do an antipsychotic, you can, there's all different things.
Okay. And irritability, what might you give someone? So, I mean, this is all, it's extremely treatable, and if you're writing your notes in such a way to say, this person screens in with high risk for suicide, and on the ASAD factors, they also appear to have high risk. I need to intervene. I need to talk to this person about, like, I believe you have extremely high risk, and we want to treat some of the things, pop some of those bubbles, like we said earlier, that are low-hanging fruit, things we know we can do something about. So all of these, we can do something about very quickly. And your notes should reflect the fact that you're treating insomnia to reduce risk for suicide, because it's a known risk, it's a known high risk factor. That my understanding is that at the VA, anytime they have somebody who has insomnia, they put them into cognitive behavior therapy for insomnia, automatically, to treat the insomnia because it's a suicide risk. Insomnia is a better predictor of death by suicide than hopelessness or depression. So, like, we can do something about that easily. We should do that. It doesn't mean you have to keep people on any of these meds long term, but if they're at high risk, they're in a high risk state right now, and we've identified them as the person who is likely to engage in suicidal behavior, it's incumbent on us to do something immediately to try to reduce that risk, collaboratively with this person, to talk to them about there is low-hanging fruit. There are things we can do right now that hopefully will make you feel better so that you can get past this distressing time. So again, the 4 of these are all present in a person who dies by suicide. Joyner talks about this as the final common pathway. That people of all shapes and sizes and backgrounds have suicidal thinking, but the ones who die by suicide have all four of these present. And that's what we're trying to identify. Who is the person who's at acute risk? This is a different model. So far we've talked about Columbia, we've talked about Thomas Joyner's ASAD factors. So Klonsky and May, other researchers who came up with a different way of thinking about suicide, and they're trying to distinguish between what drives suicidal thinking compared to what drives suicidal behavior. Two different things. So if somebody is in pain, meaning they feel like they're a burden on the world, Joyner's words, they're not socially connected, and they're hopeless, Joyner's criteria 3, then they may have suicidal thinking. Those things drive suicidal thinking. And if their pain is greater than their sense of connectedness, then they may have strong suicidal thinking. But if they're in pain, but they have a lot of meaningful supports in their life, they might not have strong ideation. So this is sort of that there's no weighting to buffers, but it is important to try to figure out, does this person believe that their sense of connection is helping them to not get into an acute state?
Well, and that I think it's also that it echoes the Joyner model in terms of social alienation. So if you have a sense of connection, then you're not experiencing social alienation.
So for Klonsky, connectedness is not just about people. Like lots of us think if you're going to group or if you're socializing on the unit that you're connected. That's not necessarily true, as the Robin Williams slide showed. But connection is what's meaningful to the person. So if they're into saving the whales or volunteering for WGBH once a month, if that's what brings them a sense of purpose and connection in the world, then that's important and that may be protective for them. The socialization with other people is part of it, but it's not all of it. So I just encourage you to think more broadly in terms of what does this person experience as being connected. So far we've gotten through things that drive ideation or suicidal thinking. And so the bottom piece of this is talking about, are you capable of making a suicide attempt? Most people aren't. So it's really, really hard to do something that's going to end your life. It's scary and it hurts. Most people don't want to do it and they can't do it. So there are, according to Klonsky, 3 classes of people who have an easier time with it. Not that it's ever easy, but some people have a dispositional capability, meaning that they're just born needing an adrenaline rush, and they live their life looking for that next rush. So it might be a guy with a motorcycle, bungee jumps, and if somebody can put themselves in risk over and over and over again, then when they get into a suicidal crisis, they're more likely to be able to follow through with a behavior, as opposed to somebody who's not such a risk taker. And some people are just born that way. Some people acquire capability by practicing, so like cutters. Right? Cutting itself is usually not considered a suicidal behavior because it's serving the purpose of helping the person to feel better, not to end their life. But the fact that somebody cuts over and over and over again habituates them or desensitizes them to what it takes to kill themselves. So when they get into a suicidal crisis and they have tunnel vision, it's a whole lot easier for them to follow through with hurting themselves because they've already been doing it for a long time. Habituation can also be acquired through your work, not by hurting yourself, but people in the military have increased risk for suicide because they're training in how to kill. Right? Dentists have elevated suicide because they're hurting people day after day after day. They're practicing. Veterinarians have higher suicide rates. Fishermen have higher suicide rates. Basically, any profession where you are exposed to death or pain, is basically helping desensitize you to that. And so then when you're in crisis, it might be a little bit easier for you than somebody who's not desensitized. And then practical capability is, has this person done their homework? Do they have any sense what it really takes to end their life? So I talked before about the example of somebody who thinks that 5 Prozac pills might kill them. Well, they didn't really do their homework, and so they might not have the capacity to kill themselves if they, do they really understand what it takes and they're capable of following through with that. So this slide is sort of tying together Joyner stuff and Klonsky stuff. So we talked about Joyner's theory about somebody having perceived burdensomeness or self-alienation or social alienation. They don't feel like they're connected. That puts somebody at risk if they get the idea that I should kill myself. They're at higher risk. But what if they don't have any capacity? This person, without any capacity, is not at super high risk. And alternately, every farmer in the world has capacity, animal farmer. They have elevated capacity, or people who cut themselves routinely have elevated capacity, but they may not have thwarted belongingness or perceived burdensomeness. So they may be doing their cutting or their farming, have elevated capacity, and they just don't get into that zone where they're at high risk. But it's the people who have all of it together who are the people who die by suicide. So you have to have the capacity to take action along with the sense of disconnection from yourself or others and a view that there's no alternative other than suicide. All of those things come together. So this is important when you're thinking about, you're tasked with identifying somebody screened in on the nursing, on the Columbia, and your job is to figure out how high risk are they right now here in the hospital. This is the model we want you to use. It doesn't mean you can't continue to use everything that you've already learned elsewhere. Like, all your clinical knowledge is still important, but this is evidence-based. This is what happens to people who die by suicide. So we want to use this model. I'm going to give you a handout of a note that I wrote that goes through using this model. Because it basically takes away the gut clinical sense and gives you something to sink your teeth into and say, you know what, there's research behind my decision now. It's not just my opinion anymore. And that has sort of not existed in the field for a long time. Historically, we've been asked to weigh risk factors and protective factors and come to a conclusion, but without any indication of how do you weigh that. And now we have something that says, well, this has more weight. If you have these ASAD factors in combination, a collection of them all at the same point in time, that's your highest risk person. That person will make an attempt, and we need to intervene.
I think of it as, I sort of divide it into like 3 parts. So the Columbia is asking about suicide-specific thoughts and behaviors. The ASAD is getting at sort of imminent risk. So do we need to act right now, or the next piece is sort of a longer term formulation about how we understand this person in their lives and their risk for suicide, and can do sort of psychosocial treatment. So you're sort of screening, identifying who's at risk, figuring out who you have to respond to imminently, urgently, and then how do you sort of formulate kind of a more thoughtful sort of treatment plan. So this is really about given that they're high risk, what do we need to really react right this moment and respond?
So would you see in the treatment plan the expectation be that their Columbia score is a 4, they are endorsing from the ASAD, very irritated, has not slept more than 5 hours in the past few days. My intervention is then going to be to maybe give them something for sleep, maybe do some cognitive behavioral therapy to develop connectedness, and maybe engage in more group programming so that they're more connected with tasks. Would that be what you would expect the whole thing to look like?
Yeah, that makes good sense, and I would just add that it's collaborative with the person, that it's clear that they understand that what we're doing here is intended to reduce your risk of suicide, that they're buying into that process, so that it's not just, I'm giving a medicine and that's going to make them better. We had a conversation about this medicine may reduce your suicide risk, and that's a treatment goal we have.
Yeah.
So this slide is basically, it's like a meta model saying that all models that talk about elevated suicide risk fall into one of three categories. That at the very beginning we talked about background factors or distal risk factors. There's always background factors that may increase somebody's vulnerability. That's important to understand about a person. There's also things that increase or that drive their suicidal thinking. So there's different models, like we talked about Joiner's model down here, thwarted belongingness, burdensomeness, but there's lots of other models. The point of this is to say, regardless of which model you adopt, understand that you're basically carving up suicidal stuff into three categories: background stuff, ideation drivers, and behavior drivers. So as you're writing your notes, you can sort of think about that, like, how much do I weigh these things? How do these things interact with one another? And the more behavior drivers somebody has, the more risk they acquire. I think that's the last slide, but I wanted to show you a note that I wrote within the past month that basically ties all this together. And I'm going to read through the note with you, and I put within the note, embedded in the note, I put in little helpers to see what exactly are we talking about as we go along. So the patient in this note was sent to the hospital from jail because she's made multiple attempts in the past, including at Worcester, at our hospital. And she's had a number of distressing events in her life, and the jail got concerned that with these distressing events and some suicidal thinking, we're worried about this person. We know she's impulsive. So they sent her on an 18A to us. So I'm going to read through this, and we'll stop periodically as we get to the points I want to make. So upon admission, Ms. Jones received a Beck Hopelessness Scale of 19. I'm a psychologist, so we use the Beck Hopelessness Scale routinely at our hospital. It's not expected of everybody. But the scale only goes up to 20. So she's almost got 100% endorsement of hopelessness on the Beck scale, which suggested that she responded to items in such a way to indicate severe level of hopelessness, which raises concern regarding possible suicide risk. In psychology assessment, her presentation did not correspond with severe hopelessness. She presented with a variety of short and long-range goals, including having already arranged for a friend to visit today. So on the day I'm meeting with her, she's already got somebody, she's a prisoner, she's already got someone from the community coming into the hospital to see her on day one. This doesn't feel very hopeless to me. She's planning to attend select groups like yoga, planning for her sister to visit, and inquiring if nursing staff or her sister can bring 2 of her children to visit. She's also focused on working with hospital staff to find the right medication to treat a range of symptoms. And she stated that in the past, a raw disorder has helped her to remain adherent to meds. She's got a whole slew of plans, future goals. Jail's concerned about her, and she comes in and like, I'm not seeing it. But like, that's not good enough, right? It's not just my clinical gut sense. I need some data, so we're going to go on. So our 18A referral documents describe concern that recent stressors and few protective factors could elevate her risk for self-harm and suicide attempt. As her history has demonstrated that during periods of severe distress, she becomes more symptomatic, which has resulted in potentially fatal actions. There was no identified recent suicidal self-injurious behavior noted in the referral documents from prison. Her mental health data sheet stated, she reports that she does not want to kill herself. However, due to her intrusive thoughts about suicide, she's fearful that she will impulsively act on her urges. In treatment team, she acknowledged a wish to be dead. So I'm going in order, sequentially, through the Columbia scale here. So she acknowledged a wish to be dead, which is level 1, with some recent suicidal thoughts, which she described as ego-dystonic voices of her deceased mother telling her to kill herself. So the thoughts are in her head. She's reached criteria 2. She reported in psychology assessment that she has considered hanging in jail as a potential method. She reaches level 3. She clearly stated that during the past month she has no intention, level 4, to end her life and no specific plans for suicide. So when I talked earlier about we want you to use Columbia language, like it doesn't get more clear than that. Like 1, 2, 3, 4, 5, it's all in her notes, very clearly using Columbia language, and we're going to make decisions based on what we just wrote. So the nursing admission Columbia suicide scale was 0, with no identified behaviors in the past 3 months, which suggested low risk. That's different than what I came up with. Based on psychology assessment, her C-SSRS rating for the past month is 3, which we just identified. All with me? Yeah. For having considered methods in jail with no intent or plans. The lifetime highest Columbia is 5 for having past intent and plans with corresponding suicidal behavior. So that's important to me. Like when I learned the Columbia, I learned on the long version, which asks you both past month and lifetime for ideation, and past 3 months for behavior and lifetime. The point of asking lifetime is so that you can contrast what is this person's risk status over their whole lifetime relative to their current risk state. 2 different assessments. So it's a good thing to put in your notes to distinguish, like this person may have some elevated risk over the course of their life because they've made attempts, but their current risk state doesn't indicate that they're at high risk. That's the case for her. So yes, I acknowledge that there's risk. I acknowledge that she has made attempts, including in our hospital. But she doesn't, I don't have any indication that she's there right now. My impression is that Ms. Jones does have elevated risk for future suicidal behavior based on her history, and at this time her current risk state is moderate, not high, based on the Columbia scale. A rating of 3 is a moderate risk, not a high risk. She stated clearly in team that she will let staff in the hospital know if she has an increase in the severity or intensity of suicidal thoughts. While team members were inquiring about her suicidal thoughts, she said, "I'm not going to kill myself if that's what you're asking." While her current risk state is not high, she does have history of multiple suicide attempts by hanging and overdose, including during a prior hospitalization earlier this year. Ms. Jones has developed the capacity to override self-preservation instinct in pursuit of suicide. This is the Klonsky stuff we talked about. She already has proven to us that she can override self-preservation. She's capable of it. So now I'm a little bit more scared if she gets in an acute state, because I already know she can do it. She can follow through. But I'm not describing somebody who's in an acute risk state. I'm describing somebody who's in a moderate state so far. This elevated capacity does increase her risk of acting on suicidal impulses in times of suicidal crisis. At this point in time, she's not experiencing a suicidal crisis. So this isn't going to be the ASAD stuff. Like, is she at imminent risk right now? She does not meet ASAD criteria for acute suicide risk. She has not had an increase in suicidal intent, criteria 1, in recent days or hours, and in fact has no recent intent to end her life in spite of suicidal thoughts. She does experience some self-loathing, criteria 2, questioning if people would be better off without her. While the 18A expressed concern that recent losses in her life could increase risk, she does not present with evidence of a sense of social alienation. So she meets one of the criteria, not both. For criteria 2, you only need to meet one of them. So yes, she meets criteria 2, partially. She does not present with evidence of social alienation, criteria 2, as she is visibly social on the unit, has friends and family with whom she is actively involved and values. While she endorses a wide range of hopeless thoughts on the Beck hopelessness scale, she does not specifically describe hopelessness about no alternative to suicide, ASAD criteria 1, and no possible improvement of self-alienation. So her hopelessness is not there in terms of the ASAD factors. So she's trying on my impression is on the Beck, she's trying for negative impression management. She wants me to believe that she is miserable, but everybody who sees her sees somebody who's completely engaged, social, not miserable, complains that she has some voices telling her to kill herself, and she doesn't want to die. So she says she's hopeless when she can endorse the questions, but when she doesn't realize that we're sort of screening for hopelessness related to her future suicidal thinking or her sense of self-alienation, it doesn't show up. She does not have tunnel vision. She sees lots of options for her future. So she does not describe hopelessness about no alternative to suicide and no possible improvement in self-alienation, which are the specific ASAD criteria. She does describe multiple over-arousal symptoms, criteria 4, including flashbacks, sleep problems, nightmares, which are decreased with the help of medication. She's currently on meds, and she's hopeful that the hospital will help improve her sleep, anxiety, and hallucinations. And then my clinical opinion, at this time she's not at high risk for suicidal behavior. So our jobs as clinicians are to render clinical opinions that in court, if you're asked, if somebody dies and somebody's auditing your chart, they want to know that you rendered an opinion. It doesn't have to be right, it has to be based on something. So I've just given a whole slew of evidence-based data to demonstrate why I don't think she's a high-risk patient. If this patient were to die, very unlikely that I would have much liability because I did a thorough assessment of this person's risk using evidence-based tools. This is what we're asking people to try to do, is use the ASAD criteria as your assessment of acute risk, consider capacity, and use the Columbia as the screening tool. And the Columbia can be repeated. So it's a screening tool on admission, but you may choose for somebody who's got high risk on admission to repeat that weekly, daily, like at any interval that you see fit to reassess the person. Thank you, everybody.
Thank you.
Thank you.
Thank you.